Now let's take a little look. We're going to move beyond diagnosis a little bit and talk about ongoing care and symptom management. To come to you, Bev. So I know that Childhood Tumour Trust have done a huge amount of work over the last 10 years looking at body maps and trying to integrate this as a standard tool put within the Red Book, which most people in the UK are familiar with, or for those outside with other health, outside the UK, other child health records. Can you explain a little bit about what the body maps are and how someone like yourself or a GP might use those?
Yeah, it's just a really simple drawing of a body. You can get for the Red Book, it's like a child body, sized body, and you can just add details to it. So you can draw onto it, annotate it, and so that it's so the one for the Red Book, you can print it out yourself. There's a link on the CTT website, or it's on healthforallchildren.com. You can print out individual body maps. I haven't contacted them for like the licensing sort of like, of mass production, like of us printing off 500 of them or whatever. There may be a cost associated with it. It's not standardly in the Red Books, unfortunately. Um, I've added it in for children that it's important for, but I would like it to be routinely in there. Uh, so then it's a parent held um the Red Book is for parents, and they've got that body map. They can take it to any professional that they go and see and say, this is what it was like a year ago, this is what it's like now. So you can use it for tracking skin changes over time as well. So it can be used for lots of things, lots of different types of birthmarks. People might have heard of like blue spots, they've got an official medical name and stuff like that, or different types of birthmarks, angiomas, things like that. So it can be really useful for recording those for professionals and for parents.
So actually, it has really good application beyond just NF1. This could
Yeah,
be used for wider skin conditions.
yeah, definitely. Yeah, absolutely. So, um,
Do you think it would be useful to have access to this? You mentioned about maybe it would be useful if it was standard in the red books. Is there, do you think this is something that should sit within GPs as part of a health record for children as well, or like
so
what's your
yeah,
thoughts
you
on that?
you get issued a red book when you're born,
Mm.
basically. So if you leave hospital, or the midwife will give it to you if you're born at home. Um, so it would need to be accessible then. So you are checked for birthmarks then. So there's absolutely no reason why they couldn't record it in a picture form, like which is actually so much better than trying to write this birthmark is zero point 0.5 centimeters by 2.3 centimeters and is of, trying to describe a color. And you can, having a picture as well as words is so much more effective. Um, the only thing is, I suppose, is that is the parent held bit. So what I would do as a health visitor is I would uh take it back to the office, scan it, and email it to the GP, and then add it to the, like, we all have electronic patient records in NHS services, so I'd add it to that as well as like a document. So that if it goes to the GP electronically like that, wherever the child or person goes, then that could always be seen if they
Yeah.
change GPs, move to a different part of the country.
I mean, I can
Parents,
see so much use of it. I mean, my son has xeroderma pigmentosum, and I think as an infant to have been able to track where his
yeah,
moles were for observation and monitoring, especially as they get older and they get hair, and then maybe things on the head are more difficult to spot, would have been
yeah.
really useful.
So somehow an electronic version would be ideal.
Yeah.
Personally, I actually got access to an app which um I don't know if I'll share the name or whatever, but it's mainly used for people with dementia. So for carers of people with dementia, but you can upload appointments onto it and photos and write notes, and then you can give permission to other people to access. So it could be your GP, it could be your health visitor by email or whatever, or different family members or the individual themselves. And so apps like that are pretty useful. So I've used that before and just taken photos of my daughter's entire body, and it's there, and then you can take it again and again. So those sorts of things are quite useful as well as a parent from my perspective of tracking changes.
Thank you. Well, from your perspective, how useful are body maps to you? Is this something you use in primary care? And if not, what are the other ways that you might use for recording it? And have you had any thoughts about like that kind of sharing across teams as to how that could be shared between parents, health visitors, GPs to monitor?
Um, so certainly the red book is looked at, but I must admit, in my experience, it tends to become both as a parent and also as a GP. It starts to become a bit redundant when the children are not at a very high age. It's sort of, is brought religiously along to appointments when you've got a little baby and maybe an infant. But by the time they're 2 or 3, it tends to not be used so much, which obviously would limit its use a little bit in this context. Something stuck into the red book. Certainly, maps are body maps are useful. Do I use them as much as I should? I don't think I probably do in primary care. So one of the settings is, as Bev has already touched it, we use an electronic health record system. Pieces of paper almost don't exist in a GP practice. And although there are body maps embedded into the electronic health record system, which you can kind of annotate, they aren't used as much as I think they could be. I think one other big opportunity here as well, which the interface between taking photos. We do an awful lot more taking of photos of skin lesions and recording, saving those to our electronic record system, both for, someone who presents with a mole that you're worried about, and we can refer, so at pigmented moles when we're wondering about things like melanomas and skin cancers, our referral pathway involves sending a photo with kind of dermatoscopes and magnified images to the dermatologists along with the referral. And indeed, all the time I'm receiving photos from district nursing colleagues about lesions on legs, ulcers. So I do think that there's a big opportunity there to digitize some of these maps, but also actually link them in with images. So we've got, and I was at a meeting the other week, and we were saying the number of times, actual fact, even referring into specialist centres for these things. Actually, we write letters and we describe cafe au lait patches or we describe skin lesions often, but now in dermatology, almost always we're sending images with our referrals. So it seems like we should be doing that far more. These should be shared backwards and forwards between health visiting, primary care, paediatrician, specialist complex service centres. So these, why are we not sending more photos around? It makes a lot more sense.
So it just sounds like a natural evolution from that kind of initial idea of the body map actually is now evolving with time and with technology into something that can become a little bit more interactive, that needs to sink in. And you mentioned there the specialist centres, which kind of leads me on to my next question, which is that we know there is a little bit of an inequity across NF1 in terms of who has access to specialist centres. Can you talk a little bit about how maybe policy and with the guidelines and things that have been written, how that could be leveraged to maybe ensure more equitable and consistent access to specialist care for people with NF1 complications? And also, I think around the definition of complex, I think there's some maybe not necessarily a consensus on what complex really means and who constitutes complex care and who doesn't.
Yeah, so I guess I mean I'll do my best to do that. There's two in England. There are two nationally commissioned complex NF1 centres. One's in Manchester, one's in London, and they have quite clear guidance about whom they're meant to see, and they're related to the complications of NF1. And a little bit like what we've talked about already is there are some people who are relatively minimally affected by NF1. So that's not to sort of belittle it, but actual fact, them having to travel regularly to a distant site for basically a hello, is everything okay? Can I have a look at your skin lesions? It is an unnecessary use of resource and an unnecessary waste of time for the individual. The challenge a little bit is ensuring that patients are looked after in the right place at the right point of their disease and in the right place in their lives, and that they can move seamlessly across those layers of care. And I think therein lies the big challenge. So when they need that complex service input, then that isn't an arduous process for them to move from where their current care is to there. But equally, actual fact, if they're under the complex service as part, and that's fact they don't need that specialty input so much, they can be moved to another part of the healthcare system that can look after them. And I think one of the challenges is almost what's happening is not only that linking across those different, but what's happening in different places. So just for context, and I'm sure everyone this will know this, but the recommendation is that all children are under the care of a paediatrician and should have an annual review with a paediatrician, and they measure certain things. But at transition, there isn't, for most patients with NF1, unless they're under the complex service, the responsibility for ongoing care is no longer with a paediatrician. It's with their GP, and even within children, there is variability in practice of how that pediatric care for the non-complex NF1 patients are looked after. So, for example, I'm a GP in Leeds and involved with the Leeds genomic service. So we always have a transition clinic, which is run by clinical genetics colleagues. So all patients at transition are seen there. But actually, if you live in Leeds, you're looked after by normally one paediatrician who looks after everybody with NF1. So he's developed, that's not his principal role, he's a general paediatrician. But obviously he sees a lot of patients with NF1 and has clear links in to the complex service who come over to Leeds to do clinics, as well as into us and the clinical genomics service. So and that model isn't everywhere. I'm very aware of that in different places that care can vary.
Yeah. Lily, do you want to pick up on that as well in terms of, obviously transition is quite topical because you're at an age where that's all very recent.
Yes.
What did transition look like for you? And have you got any insight into, again, with the group that you work with and you collaborate with, how that differs across those that might be within the complex centre and those that aren't? There are different experiences of transition.
It definitely differs a lot because I'm at the London Complex Centre and get seen there. And the transition was quite well done because we went to my last paediatric appointment, and some of the nurses there went through things, and then I got to meet who my new doctor was going to be, which was really helpful. But I know, in other hospitals where I've been seen, it's definitely not the same. It's kind of, and they're for different things, but it's kind of, you get seen and then you might get told, this is your last appointment, you will be seeing so-and-so, or you might just be kind of just told, or not even told it's your last appointment, and then it's all up in the air and you don't really fully know what's happening, where you're meant to be going, who you'll be seeing, how things will change, which for a lot of people can be quite stressful.
So there's not a sort of a consistency really across the approach? No. Okay. Just to add a note that I think Becky has popped the link to the body map in case anyone was interested. I think there were some questions around it, and that is in the thing if anyone wants to, any of the viewers want to pick that up to have a look. Thanks for that. And we're going to come to transition a little bit more, Lily, but Vi, I'm going to come to you next. Obviously we've talked about there are some quite visible signs of NF in terms of the sort of tumours, in terms of the cafe au laits, but there's also non-visible as well. How do you use community sort of empowerment and peer group support? And I know, in the youth community they do it quite well, but maybe broader as well, to help individuals cope with the sort of social impact and the emotional impact of those complications?
I think the importance of community is often underrated, but it's exceptionally important. When you live with a disability, it's isolating. When you live with a rare disability that most people have never heard of, and sadly, a lot of people go, well, if I've not heard of it, it's not that bad. So they dismiss a lot of it, and that they dismiss the impact of it on your lives. To go and be with people that live with the same disability, irrespective of what level it's at, just that they have an understanding, is so valuable. And for many people, that's when they feel they truly belong, because it's the only place where they can say something and be understood. And the weird things that nearly every disability has that nobody else outside of that community would ever understand. So to have that time together and to allow there to be time. CTT are wonderful. I love that they do their Alton Towers Day and their Chessington Day and the camps. And that's fantastic to bring them together, where it's not just activity after activity after activity, where you go and you listen to this guy talk and then this woman talk and then that person talk, and they're all talking academically, but no one's actually saying, I've got this, let's talk about it. So those things are really important, to have that sense of community. And I think it's also important to add that everyone said about there being different levels of NF1 that people live with. It all manifests differently. And within the community especially, it's very important not to put more importance on one over the other, because in that way can lead to, oh, I'm not as bad as they are, so I won't bother the doctor with this because it's not as bad as that. And then that can lead to other conditions because your body's being put through so many things that it shouldn't be put through. So instead of, ideally, don't compare at all. But if you're going to compare to anyone, compare it to Bob down the road, who's non-disabled and runs marathons for fun. I mean, surely he's the weirdo, you know? So don't respect our differences, respect that everybody in these communities have these differences.
You find that can be a barrier to people reaching out for that sort of emotional
absolutely.
support, because they feel like, I'm not as bad as, therefore I should be able to cope, I shouldn't need this help. Like, is that a barrier?
Absolutely. You know, when you're only shown a particular image, say, of what a disability looks like, if that person doesn't have, if their condition doesn't manifest in the same way, it can be, well, yeah, no, mine's not as bad, it's not as important, I won't go. So representation of all sorts of different people in the community matter too. And that's why the peer support is so important, because it's one of the few places where you can feel safe to go, I get this, do you? Well, I don't, but I know that them over there do. And it's, again, empowering that people have this opportunity to talk within their peer groups.
Do you find that adults tend to do that as well, or do you find there's kind of a cut-off at which point maybe people don't feel so comfortable being in that sort of community support environment?
I think that adults definitely get that peer support too, but then again, they also feel that, oh, my child is different.
Yeah.
So they don't communicate. And as with many disabilities, several people with NF1 also have other diagnoses too. And that's not talked about very often either across all disabilities. So someone can think, yeah, my child's got this, but they're also neurodivergent. So theirs comes out differently. I have to manage this differently. But to have the peer support for the adults as well is really important, because no matter how wonderful and how incredible the medical teams are, it's very unlikely they're living 24/7 with a condition. And so other parents, other carers are the only ones that are going to fully understand that. And it's also a wonderful way to bridge the gap. Most young people don't want to talk to their parents about certain things, but they can talk to their peers, and their peers might talk to their parent, who can then talk to the other person's parent. And it helps open doors for that parent to go, oh, I heard that so-and-so has this. Have you heard of that before? And then it opens up more conversations to allow the person to say if they want to.
I can see Lily nodding, so I know this is obviously really resonating with her, and it's fantastic to see a charity really investing in that type of support. It's really incredible.